intercostal space, mid-clavicular line. However, in a patients where having a hyperinflated lung, the lung will push the liver downwards, hence the point of the liver downwards will be lower as compared to a normal person. Now we're going to look into the classification and grading. So why this is important? Because this will form part of our management plan. Because the management will be relying on the classification as well as grading of COPD. So first we need to know about the Modified Medical Research Council, the MMRC. Of course, this I'm pretty sure most of you are familiar with this. 0, 1, 2, 3, 4 is to be quantified based on the patient's symptoms. So results reported by the patients. And then second thing we need to know is the ABCD assessment tool classification. So this is as per outlined in gold guideline of COPD, where we have the gold 1, 2, 3, 4, as well as the category A, B, C, D. So if you go to suspect, for example, if you happen to look into the BHT, to the system, pesakit, so you can see that the classification used will be using this classification. We can see patient gold A1, 1A or A1, for example, like that, 3A or 1-3, AA3. So these are the classification that is being used. So you can try have a look at the pesakit. These are usually part of the underlying status. They will put what is the gold and what is the ABCD of the particular patient. So you can do this by classifying based on the respective criteria. So as I mentioned before, that it is reliance on few things. Sorry. First and foremost, the just a second. Okay. We need to know the MMRC of the patient. So 0, 1 will be classifications of A or C. 2 or more will be B and D. And then this is for the x-axis of this table, of this box. And then for the y-axis, we can see either 0 or 1 admission, or 2 or more, 0 or 1 exacerbations not requiring admission, or 2 or more requiring admission. 2 or more not requiring admission, or 1 or more that require admission. So these are what we, based on these two, this y-axis as well as this x-axis, so we can put the patients into A, B, C, and D. So this is important. I will show later on because it will guide our initiations of medications for stable COPD. Now we're going to look at some of the complications that we need to look for in our history as well as in our clinical examination. So first is the core pulmonary or the pulmonary hypertension. So it is postulated that because of the chronic hypoxia, it will lead, and also because of the emphysema, eventually there will be a remodeling of the pulmonary vasculature. So this remodeling of the pulmonary vasculature will increase the pulmonary resistance, hence eventually leading to pulmonary hypertension. And in the long course of a chronic and also advanced stage of COPD, patients might have a right ventricular heart failure because of the pulmonary hypertension. However, the incidence of right ventricular failure, right-sided heart failure in a case of COPD is actually declining since the advancements of oxygen therapy. Second will be the respiratory failures, of course, because of the it can be type 1 or type 2. Type 1 will be hypoxic and type 2 will be hypercapnic. And also patients might are predisposed to having a pneumothorax. And of course, indirectly, because one of the largest risk factor is actually tobacco smoking. So in CPG, it also included lung cancer as part of the complications that might arise from a patient. So these particular complications are to be sought for in our history examination. And also some of the investigations are to look for these complications also. Now, investigations of COPD, of course, we're going to divide into the traditional methods of bedside, blood, as well as imaging. For the bedside, we can do a lung function test either by PEFR or spirometry. However, during acute exacerbation, when the patient is admitted in an acute setting it is not to be done spirometry or PEFR because it is not reliable. Hence, we will, after discharge of the patients from the hospital, then we will arrange for a spirometry test. So an FEV1 over FVC ratio of less than 0.7 will be a diagnostic features of COPD. And actually, PEFR we can use to aid our diagnosis, but for example, in primary care, we don't have spirometry as readily as accessible as compared to the tertiary clinic. So in primary care setting, we can use PFR. However, it have a high sensitivity but low specificity. So a low PFR might be COPD, but it also might be something else. So for those who are treated in a primary care center, in a family medicine center, KK whatsoever, then even though they already do the PEFR, we need to refer them to tertiary center for a proper spirometry for a diagnosis to be done. Second will be ECG. ECG is to look for the complications, which includes, as mentioned before, cor pulmonale. So what we can see in the cor pulmonale will be a tall P wave, P pulmonale. So you can see the P wave, it will be taller. And also for those, we can also try to see for the right ventricular hypertrophy by looking at the right-sided leg, especially at the R wave. R wave will be higher as compared to the S wave in leg 1 for those having a right ventricular hypertrophy, as well as sputum CNS. Of course, for any patients having the infectious causes, we need to take the culture and sensitivity. However, for the sake of initiation antibiotic, we just need a clinical condition criteria, but culture and sensitivity will facilitate after we give the empirical antibiotic. Then we need to tally accordingly to the culture. So this will aid in the antibiotic administrations later on. Blood will be FBC. We can see anemia of chronic disease, or we can see a polycythemia because of the chronic hypoxia. So as we know that a chronic hypoxia will be a stimulant of erythropoietin release from our kidney. Hence, it will promote the erythropoiesis as part of the compensatory mechanism because of the chronic hypoxia. ABG will be important to know if the patient is in failure or not, and as well as to know if the patient is in respiratory acidosis or not. Blood CNS as part of the septic workup, as well as other investigations will be RP, LFT, but this is not really diagnostic, but rather it is more of a baseline baseline. Some lecturer don't prefer a general investigation. Some prefer to have a directed investigations to the diagnosis, but but CBG just listed out. Of course, imagings will be chest X-ray, so we can see signs of hyperinflation. So these are also favorite questions by the lecturers. What are the signs of hyperinflation? So we can see the hyperinflated lung in the case where we calculate the anterior rib as well as posterior rib, how many ribs are visualized. So if you refer to Radiopedia, then they say more than 6 anterior rib and more than 10 posterior rib would be a sign of hyperinflation. And if we refer to Armstrong textbook of radiology, then they will say that more than 7 anteriorly and more than 12 posteriorly will be indicative of a hyperinflated lung. And also we can see that the heart is a tubular shape. So imagine that the heart is in the mediastinum, surrounded by 2 lungs. So when the lung is hyperinflated, it will push the heart. So the heart will appear as if it is a tubular shaped heart. And also because of the hyperinflated lung, logically the hemidiaphragm will be flattened because usually we can see the hemidiaphragm, but because of the lung has been hyperinflated, so it will push the diaphragm outwards. And then we can see the bulle. So bulle is actually a air-filled space within the lung parenchyma. It occurs for COPD because of the emphysema, the dilatations of the airway. So bulle we can see as paucity of lung marking on chest X-ray. So bulle, if we refer to William textbook, it is defined as lesion more than 1 centimeter in size, having a less than 1 millimeter of wall. So we show examples of bulle as seen in chest X-ray. So if you can see here, this is what we call as a bulle. So we can see a very fine, well-demarcated lesion, and there's a paucity of the lung marking. In other words, we can see some lung marking, lung vasculature here, but it is not seen here. It is loosened here. So that is what we call as the paucity of lung marking, indicative of a bulle in a COPD patient. So if you see a proper chest X-ray, then we can see that the heart is a bit tubular in shape, and the hymen diaphragm is actually flattened below. And we can calculate the anterior as well as posterior rib, how many are seen and how many are able to be visualized to indicate that the patients might have a hyperinflated lung. There are other tests, for example, the diffuse lung capacity for carbon monoxide, but I will not be touching on that because it is not done in our clinical practice, and so on. Now, favorite questions also by our lecturers will be how to differentiate a COPD from a bronchial asthma, as both are a chronic respiratory conditions with more or less a similar symptomology. So there are few differences that we can see. This is table taken from CPG of COPD. So these are the tables. So we can see first and foremost the age of onset. As I mentioned before, COPD usually more than 40 years, except for those having the genetic problem. Bronchial asthma, because it is an atopic condition and because it is highly intercorrelated with genetic factors, hence it usually presents with early childhood. However, patients can still have an adult onset of bronchial asthma. Smoking history, it is what we say pathognomonic of COPD, but not so for bronchial asthma. Atopic history, the allergic conjunctivitis, allergic rhinitis, as well as the atopic eczema. It is often seen in asthma, but it is not really seen in COPD. Family history, of course, asthma, it being atopic, then we can see atopic history in the family, but not so for COPD. Clinical symptoms, if we see that asthma, because it is a reversible airway obstructions, hence the symptomology is actually intermittent and variable as compared to COPD, where the obstruction is actually non-reversible and it is progressive in nature. So we can see that the state of COPD, it will always run a gradually worsening course of disease, whereas asthma, it have a variable course of disease as compared to COPD. And then cough, of course, asthma characteristic cough will be a nocturnal, and sputum is usually not be seen in asthmatic cough as compared to COPD. Sputum would be a copious amount, and usually the cough will be occurring at the morning. Reversibility of airflow will be characteristic of asthma because we have the reversibility test, post-bronchodilator test. If it is positive, then it is indicative of asthma, but if it is negative, then it suggests COPD. Of course, exacerbations have some difference in terms of these two conditions. Okay. Another topic to be discussed will be asthma COPD overlap syndromes, or known as the ACOS. So if you look into definitions, as per outlined by our CPG, it would be a persistent airflow limitation with both features of asthma and features of COPD as well in the same patient. So if we refer the old guideline, gold ACOS, asthma or COPD over 2015, I can share the guidelines later on in the group for those who are interested to read on it. 2015 publication. So for these particular conditions, then it is more important for us to treat the asthmatic component as compared to the COPD component, because it is shown that the risk of mortality from having a mild asthma is higher as compared to COPD of various stages. So we treat with ICS in low to moderate dose, and then we plus minus LABA or LAMA. Okay. So yeah. Okay. So, however, if we refer to GOLD 2020, last year publications, that they state that we no longer refer to the ACOS. Instead, the committee of GOLD guidelines say that these two entities are different altogether. But those two conditions might coexist in the same patient. Okay. If you see it here, if a concurrent diagnosis of asthma is suspected, pharmacotherapy should primarily follow asthmatic guideline, but pharmacological and non-pharmacological approach may also be needed for the COPD. So it is more important for us to treat asthma because their mortality is higher as compared to mortality from exacerbation is higher as compared to COPD. Of course, now we move to the next part would be the management of COPD. So I divide this management part into two main components, primarily of treating an acute exacerbation. The second part will be treating a stable COPD per se. Now, these are the flow of the flow chart for management of acute exacerbation of COPD as taken from our CPG. So this is actually if you go to the ward, this is what is being done in the emergency setting as well as in the inpatient setting. So you can just memorize this flow chart. Then I believe it is more than good enough. So as part of the outline of management, so we kind to cover 7 things. First will be the management setting when we decide that the patient is to be treated as an inpatient or as an outpatient. Second will be the controlled oxygen therapy. The third one will be the administrations of bronchodilators. Fourth one will be antibiotics, corticosteroids, supporting measures, as well as what are the criteria for discharge and what is to be done on follow-up. Of course, all of these are actually summarized written in this particular flowchart, so you can just memorize this flowchart. But for the sake of going into the details of discussion, so let us have a look on each one of these components. First and foremost will be the management setting. So these are the indications for us to admit a particular patient as an inpatient. For those not having this criteria, so we can treat them at the emergency and then discharge home. So these are some of the features. So you can see we have the disease factor as well as the social factors and the patient's factor. So you can read into the details of this list later on, taken from CPG also. Now the next part of the presentations will be the controlled oxygen therapy. As we know that these patients will be in a hypoxic state, hence oxygens will be important in their treatment. So if we refer to CPG, then they mentioned that in acute exacerbation of COPD, oxygen is to be instituted if the SpO2 is less than 90. It is to be maintained between 90 to 93%. If we refer to GOLD guideline, then they say that 88 to 92%. Either one, you can just use either as long as you can quote the sources respectively. So the problem is with oxygen therapy for COPD patients, if you notice in the ward, they don't put them on a high oxygen flow. For example, if you see those on cannula, nasal cannula, they don't put, for example, we can put up to 5 liters per minute of oxygen, but they don't put it as high in COPD patient because this is also a favorite question by lecturers because they are in a state of a chronic hypoxia, meaning that they've been living their life having a hypoxic state. So this hypoxic state, what we call, will lead to a hypoxic drive. In other words, this hypoxemia state is what drives their respiratory center to be activated in order to initiate the respiration, the inspiration as part of the respiratory cycle. So if we give too rapid or too high of an oxygen, then the body will be not they will lost the hypoxic drive and the patients cannot initiate their breathing center. So the patients might be deteriorate instead of being helped by the oxygen therapy. Hence, the term is controlled oxygen therapy. So of course, using a venturi mask is better because we have a different, color coding, have a different oxygen saturations that we can give. So it's better to use Venturi mask as compared to nasoprom because it's more controlled. We can actually control the amount of oxygen. So, of course, if that doesn't work, then we need to proceed with non-invasive ventilation, which include the, either the CPAP or the BiPAP. So, common questions also by lecturers: what are the differences between these two? So, CPAP, continuous, positive airway pressure, is that throughout the cycles of respirations, both the inspirations as well as expiration, there will be a constant pressure being exerted on the patients. So imagine we put a mask to ourselves, then there's a pressure during inspiration, so it will facilitate our breathing. And when we want to exhale out, there will be also pressure going against our exhalation. That is what CPAP. So if you can notice in the word that CPAP is usually used for heart failure patient because we want to open the patency of the alveoli to ensure that the patients can breathe. And also another modalities of non-invasive ventilation will be the BiPAP. So BiPAP, we can adjust how many pressure during inspiration, how many pressure during expiration. Uh, these are indications for the non-invasive ventilation. So if you can see that after giving the nasal prong or the venturi mask, if the patient's having this criteria, or in other words, if the patient is still worsen in terms of their acidotic and in terms of their respiratory rate, and in terms of the symptoms, so we up the ante with an IV, non-invasive ventilation. Of course, there are some contraindications to non-invasive ventilation, mainly being for those who cannot protect their airway. For example, unconscious patient, for those having copious amount of secretions that are at high risk for aspiration. For example, those having intestinal obstructions because they are at risk of aspiration. Also, it is not to be used for those with cardiovascular instability, and it is not to be used for those with facial injury, of course, because CPAP or BiPAP, we need to apply the mask to the face, right? So if it cannot be used for those with a facial injury whatsoever. Now, and also if that does not work, then we need to up the stage with invasive ventilations, which includes either ET tube, intubation, endotracheal intubations, or tracheostomy. So these are the indications for invasive mechanical ventilation. Of course, having said that, we move by stages. We don't simply jump to the more invasive one. We go from the least invasive to the most invasive in accordance to the stages of the patient. Third part will be the bronchodilators. So what is being used in AECOPD, acute exacerbations, will be the SABA plus minus SAAC. So if you go to the ward, commonly prescribed will be a Combivent, which is a combination between ipratropium bromides as well as salbutamol. Combination between those two, SABA plus SAAC. So if you go to open up the medication chart, so they will give a 6-hourly basis. You can see both in HTAA as well as, I'm not sure about Duoven, but Combivent is always be seen. You can see easily in the ward. However, if we give this bronchodilator, it is not responsive, then we need to consider giving metazentine if there is no response. So metazentines, the dose are per stated to be given intravenous. The last part will be antibiotics. So as I mentioned before that, we antibiotic therapy, we have the prophylactic therapy, we have the empirical therapy as well as the therapeutic antibiotic. So prophylactic refers to, we are anticipating infections to occur, hence we give prophylaxis before the infection occur, for example, before surgery. Empirical therapy is where there is infections, but we cover at a broad spectrum because we don't know yet what are the affecting pathogens. And therapeutic will be once we get the results of culture and sensitivity. So for empirical antibiotics of COPD, acute exacerbations, we don't need the culture result yet. We just need 2 or more of the following criteria, which includes the worsening of the symptoms, dyspnea, increase in sputum volume, as well as increase in sputum, the quality will be more purulent. 2 or more of this will be enough for us to start empirical antibiotic. So the culture and the sensitivity taken from sputum as well as from the blood would be tailored, will be as a guide for us to change after empirical. We want to change to therapeutical antibiotics, which is directed towards the specific organism. So this is the list of antibiotics. So if you notice that this is actually taken from the National Antibiotic Guideline 2017 ke 19, tak ingat. 17, I'm not mistaken. The latest one lah, basically. So if you notice that it's basically the same with pneumonia antibiotic. So we have the augmentin to be given if outpatients giving per oral, if inpatients giving intravenous. If you see the dose, it's also the same as what we can see in pneumonia, community-acquired pneumonia patients. Augmentin 1.2 gram IV TDS for 5 to 7 days plus azithromycin. Azithromycin is to cover for the atypical organism because they lack the cell wall. So actually, this is the same with community-acquired pneumonia. If you happen to get the chances, you can go through the guideline, and you can also go to the ward, see the antibiotic being given is the same lah. The last will be the corticosteroids. So we give a course of oral prednisolone for 1 to 2 weeks. But if the patient cannot swallow or the patient is vomiting, so we can consider IV hydrocort 100 to 200 mg. And of course, having said that, we have some supportive measures for acute exacerbation of COPD. So if you see at the flow chart, we can see this lah. So management of the fluid, and also the prophylaxis against the event thrombosis. So we give the subacute heparin, as well as nutrition and also sputum clearance. So we have the chest physiotherapy. You can see in what being done by the sometimes by the doctor, but sometimes by the apa nama orang tu yang chest physiology lah, basically the chest physiotherapy where they tap chest and then repetitively in order to try to induce the sputum to go up. You can see in patient in ward. So discharge and follow up. So these are the criteria for discharge, and these are what are the things that is need to be done for subsequent follow up. So after we discharge, we need to review back after 8 weeks post discharge. Okay. So I've covered about the acute exacerbations of COPD. In other words, patients presenting with the exacerbations. So now we're going to have a look on. This title should be a stable COPD because we already covered the acute exacerbation of COPD before. So these are the outline of management of a stable COPD. The outline of management would be primarily based on our ABCD classifications code before. These are the outline. We have the smoking cessations, vaccinations, bronchodilators, anti-inflammatory agents, long-term oxygen therapy, pulmonary rehab, as well as surgery. So we're going to look into bits of these points later on. Smoking cessations, of course, this will be one of the most important, interventions that need to be done, because as long as the patient is smoking, then the risk of, first and foremost, is the risk of getting the disease. But for those already having the disease, smoking is, detrimental in terms of the progressions of the disease. So smoking cessations will help, facilitate the patients to improve their conditions. So these are the 5A as what we learn in family medicine posting. So of course, if you can give these points during the professional exam or during the exams, I would say the lecturers would be impressed lah. Vaccinations. Of course, there are 2 vaccinations. First and foremost, against influenza. Second will be the pneumococcal vaccine. So if the patients can afford to do so, then we can advocate the patients to do vaccinations because it is not currently covered. So if the patient is able to afford, then we give lah. And then third one will be the bronchodilator. So bronchodilator, as the name suggests, to promote the dilatations of the bronchial airway. So we have the anti-muscarinic agent, as well as, or the anticholinergic agent, as well as the beta 2 agonist. So if you see, these are the summary of the bronchodilators that are being used in stable COPD. I summarized it and I took excerpts from the guideline of Code 2020. So LABA and LAMA is shown to function. So in other words, both are important, and it is shown that combination therapy as compared to a monotherapy. So it is shown that the effect of combining LABA and LAMA is better as compared to either one alone. And if you want to compare them alone, it is shown that LAMA is actually better than LABA. So yeah, just a bit of pharmacology. So beta 2 agonist drugs, they will act on the beta 2 receptor. This will stimulate the CAMP formation, hence promoting the relaxations of this bronchial smooth muscle cell, uh, hence promoting the dilatation of the bronchus. Or the anticholinergic agents or the anticholinergic agents, basically they will antagonize the effect of acetylcholine on M3 nicotinic receptor, because these acetylcholine actions on the nicotinic receptor will promote a bronchoconstriction. So when we antagonize them, of course, we will promote bronchodilatation. So that is the basic pharmacology behind these group of drugs. So again, as a summary, both are important. If we got to compare alone, LAMA is better than compared to LABA, but combinations of both is so of course, another part of bronchos will be the theophylline as part of the methylxanthine. However, methylxanthine is not recommended in the guideline because of its side effect profile. It is only to be used when you have a poor response towards LABA and LAMA combinations. Now, these are some of the drugs, and also it's you can see, just memorize a few lah. Don't need to memorize all. Okay, anti-inflammatory agents. So first, we're going to see the corticosteroids. So we have two, either inhaled or oral. So oral is actually not shown to be beneficial in terms of management of a stable COPD. So we have oral prednisolone for those having acute exacerbations to be given in 1 to 2 weeks. But for stable COPD, it is not shown to be beneficial whatsoever to give the systemic corticosteroids. But inhaled corticosteroids is shown to be effective. And then we can see the PDE4 inhibitors. So it is shown that for those having a recurrent bouts of exacerbations, then PDE4 inhibitors will be beneficial. And then in terms of antibiotics, again, for those having frequent exacerbations, it is shown to be beneficial that we prescribe the patients on macrolides, which includes the azithromycin and as well as the erythromycin therapy to reduce the exacerbation. And then we have the mucotic agents, as well as other inflammatory agents, which includes simvastatins and also the leukotrienes modifier. However, these two are not given in our case. So yeah, of course, we're going to see the details later on. How do we initiate? So as I mentioned before, that it is very important for us to know this classification because it will aid us to start our pharmacotherapy for the patient. So based on the group of patients, group A, B, C, or D, then we can decide on what to start the patients on. So if the patient is on is group A, so it is shown that any bronchodilators is beneficial for the for the patient's condition. So we can start the patients or LABA, LAMA, or LAMA, or we can also start with SABA or SAMA. So it is going to be beneficial. Group B would be LABA or LAMA, either one, compared to LABA lah, in a case of monotherapy. Group C, LAMA. effect in terms of reducing the exacerbation as compared to LABA in a monotherapy setting. And group D, we can consider to give what we call as we can combine lah, either LABA plus LAMA or ICS plus LABA. And then if still not improving, then we will see later on what we're going to do. So these are the initiations. So how do we start? We based on the gold classifications, the refined ABCD assessment tool. Then after that, we need to adjust accordingly. So there are two pathways that we need to know. Either we are concerned with their dyspnea symptom, or we are concerned more of their exacerbations. But if we are concerned with both, then we follow the exacerbation pathway. So we can see that we start with LABA or LAMA, then we add in a combination therapy, either LABA plus LAMA or LABA plus ICS. And then what we call, if another step up, would be the LABA plus LAMA plus ICS. This is also known in the guideline as a triple therapy. So where we combine LABA, LAMA, and ICS. So we can, decide to escalate the patients, in a stepwise manner after we review the patients. So we need to see these two components, exacerbation and have a good, discussion with the lecturers, then you might be asked with this lah. Long-term oxygen therapy is where we give the patients, mobile oxygen therapy to be brought home to be administered on a daily basis. So it is a long-term oxygen therapy. Sorry, apparently my Wi-Fi crashed. I was informed that it is disconnected since the long-term oxygen therapy. Yeah, just a second. You know, these are the indications for the long-term oxygen therapies. The PaO2 of less than or more 55 millimeters mercury or less, or the SaO2 of 88% or less. This is a common questions in OSCE, as well as if you happen to have a good discussions on long case, you might be asked with this lah. This is the pictures of the oxygen therapies. So you can try to Google and be familiarized with the pictures if it happens to come out in OSCE. Of course, the one of the points importance will be the pulmonary rehabilitations. This is a service aimed at intervention, a set of interventions being done directed to improve the lungs respiration. So, not all centers have this facility, and a proper referral must be sought in order for us to give the patients the chance to rehabilitate their lungs. So, you can just take a note on this. The points are being well described in the guideline. The last one will be the surgery. So these are the set of interventions that we can do in order for treat the COPD. So you might get these questions if you happen to have a good discussions on COPD. So the lecturers might ask you what are the surgical options available. So we have the lung volume reduction surgeries, bolectomies, transplantations, and also bronchoscopy intervention. So I will not go into the depth of these discussions. You can just read descriptions. It's already self-explanatory. That's all for my presentation today. So I think that's all. So just I open the floor for any questions that you might have. We will go through lah. Just you can ask directly, or if you prefer, you don't prefer, you can just pop up the questions in the chat box. So sorry, the internet suddenly crashed. Bronchodilator participant development. Oh, okay. So because we need to do the give the bronchodilators, because we need to do the reversibility test, because in an asthmatic patient, after we give the the bronchodilator, after that we will see an improvement of a certain a value, but it is not to be seen in a COPD patient because the airway is not reversible. Okay, any other questions pertaining to the topic that you would like to ask? Don't worry, I will share the slide. Sorry for the sudden disconnections. Apparently the Wi-Fi is not really stable.
Dr. Aqlan, if you need to consider non-invasive ventilation for COPD patient, the preference would be CPAP or BiPAP, or could be either one.
Okay, thank you. That's a very good question. So, in the case of we have two options: the CPAP as well as the
BiPAP. So we've asked before with Dr. Fahana. So Dr. Fahana mentioned that BiPAP is actually more useful in COPD because we can modulate how many we want to inspire, how many we want to expire based on the pressures, adjustment. Because COPD is a very, we need to very strict control of oxygens need to be given. But if you open the guideline, it's actually not stated anywhere which are preferred. This is just a verbatim answer from Dr. Fahana lah. And also she mentioned that but in the guideline it mentioned that for COPD with a comorbid obstructive sleep apnea, then a CPAP will be beneficial lah. But it does not state specifically whether to choose BiPAP or CPAP. But the verbatim answer from Dr. Fahana is BiPAP lah. If I have any additional points on this, I will share lah in the group. Okay.
Right, thank you, Doctor.
Next question, it is common COPD in non-smoker patient. Is it similar management? To be honest, I don't see much of a non-smoker patients except for that particular boy lah. You can try to find lah. I've plugged him few times before. No, to be honest, no, not really common. Why COPD does not have clubbing? Okay, of course, one of the favorite questions by Prof. How, usually if you happens to get him for your exam, he will always try to bait you into this question lah. Does COPD have finger clubbing or not? So actually, no, they will have finger clubbing because if you look into the Taylor O'Connor, the pathophysiology of the finger clubbing per se is actually because of the destructions of the vasculatures of the pulmonary vessels, which leads to the emboli to the megakaryocyte to pass from the systemic pulmonary circulations into the systemic circulations, hence be deposited at the end of the fingertips, at the end of the vasculature bed. So these megakaryocytes will then be proliferated, so leading to the finger clubbing. If that's one of the postulations as per outlined in the COPD, in the Taylor O'Connor, in terms how it explains how a finger clubbings occur. So in a COPD patients, no lah. To be honest, I'm not quite sure why no, but yeah lah, it's memang tak lah. Usually, Prof. How ask, if TB have finger clubbing or not, if COPD have finger clubbing or not. Usually a trap question. Yeah. You can see the list as outlined in Taylor O'Connor. But to be honest, I'm not quite sure why. No. ICS indicated. Yes, it depends on the itulah yang as I mentioned that the ABCD where we want to initiate. If the patient's already in stage D, then we can start straight away with combination therapy. Either we give the LAMA or LAMA plus LABA or the plus the ICS. Stable COPD, yes, indicated. Depends on the stage and depends on our assessment. So if we happens to start the patients on the bronchodilators without ICS, then after follow up we see that the patients require ICS, then we step up lah, we give ICS. But oral is not beneficial lah in a stable COPD. Okay. Any other inquiry?
Doctor, why Maxoff is useful in acute asthma but not in acute COPD?
Oh, Maxoff. To be honest, I'm not quite sure about that. I'll search for that. If I happens to come across the answer, I'll share. So sorry.
It's okay, Doctor. Thank you.
Perhaps anyone yang tahu ke boleh dia share. Tak ada masalah. Okay. If no, then I pass the floor to the
cooperation to turn on your camera to take a picture with our speaker for a memory. I give you a few seconds for that. Thank you.
All the best for the coming interval. Sorry for the slight inconvenience just now. So just happens that just want to say that just do your best in whatever stage you are currently on, either you are in preclinical, clinical, or in final year. So inshallah, hopefully that is the efforts that we put is actually more important